Thank you for having me here. It's a great pleasure for meet Professor Curiglian. It's very difficult to pronounce, and also Professor Mei Hen. After we saw the paper published by Liang Wenhua at the Lancet Oncology, indicating that cancer patients have a higher risk for COVID-19. But the thing is that the definition of cancer is very heterogeneous. It includes a lot of cancer types, including the solid tumors, lung cancer, breast cancer, colon, and also the hematology malignancies. And also the stage range from the early stage, the advanced stage, and also some locally advanced stage. So the definition and the stratification of cancer patients varied. And also for the incidence or the prevalence of cancer patients of COVID-19 infection, we should consider their comorbidities, their age, their immunostatus, and also the treatment they receive. Just as Mei Hen has published on Lancet Oncology, the patient receiving chemotherapy might have a higher incidence for infection, but the patient receiving tyrosine kinase inhibitor or other immunocheckpoint inhibitors might not. So the thing is that if we would say that all the cancer patients have a higher risk, we cannot conclude that. So I want also hear the opinion from Professor Curiglian, because you have published a very great paper, and I have read it in European Journal of Cancer regarding the checkpoint inhibitor in the era of COVID-19, maybe in some cancer patient or some non-cancer patient as well.
So Professor Peng, so for sure we can, I completely agree with you that cancer patients have a higher risk of mortality compared to non-cancer patients. But in the context of multiple comorbidities and older age, so I agree with you that not all cancer patients have higher risk of mortality. Because if we look at the data, the first data published on the Lancet Oncology by Euro cases, and finally, if we look at data from CCC19 and Teravolt, it's quite clear that we have three important risk factors: older age, comorbidities, and use of chemotherapy. So it's quite clear that if you have also a lung cancer and you are older, you have comorbidities, and you use chemotherapy, your risk will be higher, of course. So my final message is that yes, you have higher risk if you have cancer, not for all the type of cancers, and related to comorbidities and older age.
Yes, of course. And also for the thing of checkpoint inhibitor, for the prognosis of cancer patients, I have read two papers from Memorial Sloan Kettering Cancer Center. One is from the Department of Thoracic Oncology and one from infectious disease. And I suppose the latter, the second one has not been published. It's also a preprint. But the thing is different. The conclusion might be different. The first one published by Luo et al., and they say that ICI does not impact the prognosis. And the second one saying that ICI has adverse impact for the cancer patients. They include all the pan cancer, including hematology and lung versus non-lung cancer. So different conclusions for kindly the similar data set from a center. Why is that? Due to the baseline variables or the different statistic analysis? I don't know. I want to hear your comment and also from Dr. Mei Hen's comments.
But you know, we don't have a clear demonstration that immunocheckpoint increase the risk of mortality, because both in CCC19 and in Teravolt trial, immunotherapy is not a negative prognostic factor. So maybe you are right, are the baseline factors of the patients that maybe can increase the risk of mortality in patients receiving immunotherapy. You know, in my institution, we have a database of almost 400 patients receiving immunotherapy for melanoma, and no one died during the COVID pandemics, even if got the virus. So it's quite clear that it's patient by patient and according to other comorbidities.
So I'm in Wuhan, so I witnessed a massive outbreak of the coronavirus disease 2019 in the center. So then from Wuhan to world, became a pandemic. So as oncologists, we are also involved in this battle to contain the relentless spread of the epidemic. I think from January, middle of January, to the end of February, I'm working on the front line, and after that, our friends from Zhejiang and other provinces and give us a lot of supplies. Then we can have a rest. So during 1.5 months, I think we have to look after more than 1,000 cancer patients, including more than 150 hematological malignancies. Unlike many other patients, I think the immunity of these patients with cancer is often compromised, and they heavily depend on the availability of medical resources. At that time, the resources is very short, which renders them extremely vulnerable to the impact of the epidemic. And therefore, that is a very tough time for challengers. So during these patients, I think for first, I agree with you that these cancer patients, the infection rate is higher than normal patients. We have investigation for these patients. The infection rate of cancer patients totally is about 2% of infection rate. That is 5 times higher than the population in Wuhan, so much higher. And for the fatality, I think it is also fatality rate is also very high, especially in hematological malignancies. For hematological malignancies, there are 6 patients die during the 13 patients, nearly half of them. But for solid tumor, there's only 2 die, so much lower than blood cancer. So I think blood cancer is more dangerous for these patients. And another thing is for the treatment. I agree with you that in this tough time, we should use some low-dose chemotherapy, or even better with the oral touched drugs. So I have a statistic of 33 patients with cancer with COVID-19. We found that 8 of them treated by targeted therapies, including kinase inhibitors such as TKI and BTK inhibitor. And I remember 2 of them with multiple myeloma. We gave them proteasome inhibitors. And 2 lymphoma patients, they received the immune checkpoint inhibitor, PD-1. Most of them are very front for this treatment. Even they infected with COVID-19, but the outcome is good, much better than other patients received heavy chemotherapy. And during that time, we stopped our transplantation unit, so no people received transplantation. So I think the treatment strategy is also very important for them. And for the other things, I agree with Professor Curiglian. That is, age is very important. We submit a paper to National Hematology. In this paper, we investigated more than 380 patients. The median age was 64, and we found that compared with the moderate patients, the severe and the critical ill patients, they have significant older, their age are older, and nearly half of them have the comorbidities such as hypertension is very common, and some have diabetes. Actually, diabetes is also very dangerous for them, and some patients they have coronary heart diseases. So I think the comorbidity is also very important for these patients' prognosis. That's what I know now. Thank you.
Thank you. I also have a question for Professor Curiglian. due to the reason that ACE2 expression has something related to the COVID-19 infection. Do you think anything to do with age and also the gender preference for ACE2 and other things like smoking history? And I have also read a paper indicating that the altitude, the higher place, the decrease the ACE2 expression because the altitude has decreased the expression of ACE2, making that people living higher altitude are less prone to COVID-19 infection. So can we say that different gender and different age have different ACE2 expression that might lead to different prevalence of COVID-19 in different countries?
So I read with interest your paper published in the European Journal of Cancer. Your analysis from TCGA clearly show that ACE2 is much more expressed in normal versus cancer tissue, both in breast and liver hepatocellular carcinoma. You know, we did a study in Italy. It seems that higher altitude may decrease the risk of infection. We have much more male patients respect to female also in our country. Out of 35,000 patients, I can tell you that 70% of them were male, and the mortality was higher in male respect to female. But all of these are statistical observations. I am not so sure that ACE2 is not important. Maybe it is very important, as you stated in your manuscript to European Journal of Cancer. What we need to understand is the polymorphism. So maybe we will discover that some patients that have a specific polymorphism may have a worse outcome with respect to other patients with another polymorphism. And this can also explain also the gender difference between male and female in mortality. But an important observation in your paper is the one related to prostate cancer, because it seems that in your analysis, in prostate cancer, there is no difference. And some other people are claiming that maybe since there is another target in prostate that is a target of the virus, maybe the anti-androgen therapy may have a protective effect on prostate cancer patients. So overall, I believe gender may have an impact, maybe to ACE2 polymorphism. For sure, there is an effect. Regarding to environment, latitude, higher altitude, this can be possible, of course, but we need to demonstrate this.
Yes, yes.
In any case, the latitude of Wuhan, Milan, and New York are the same. So if you consider the latitude of Wuhan, Regione Lombardia, and New York City are exactly the same.
Yes, and I have another question regarding the difference of this virus from other SARS-CoV virus, because we saw the paper on New England Journal of Medicine published by Mount Sinai Hospital that the young age patient, middle age patient, they have COVID-19 and develop very quickly to severe illness and have clots in their vessels. Science paper indicated that the virus attack the vessels will be the second phase of COVID-19. So why that has a second phase? Why some of the patients develop so quickly to the deadly ill, and sometimes the aged one, the old one, does not develop that quickly compared with the middle-aged one. Why is that for the vessel attack for this virus? I also wonder this question.
ACE2 is expressed in endothelial vessels, finally. And so you have the binding of the virus with the spike on these specific receptors. And in the New England Journal of paper, it's quite clear that you have an endothelialitis, this is the name, with the induction of microclots. So you have a microthrombosis that is quite clear to be described also in the lung of many patients that underwent autopsy. So you have different mechanisms. One is inflammatory related, and another one is thrombotic related. And I would like to know from my colleague from Wuhan if you did autopsies and what you found on the lung of patients with COVID-19. Did you find all these microclots and these endothelialitis or not?
So I have a question about the treatment. We know now the for mechanism for COVID-19, the cytokine storm is very important. So do you use these medications to interfere with cytokines in Italy, such as the IL-6 inhibitor or GM-CSF inhibitor or something else? So what's your comment about that?
But you know, when we started with the pandemics, a task force from Wuhan came in Milan, and we started exactly the same trial with tocilizumab that you started in your country. I must confess that in very advanced cases, there is no activity of tocilizumab. We observed some activities just at the beginning of the infection in order to reduce the cytokine storm. We did also a study with the anti-interleukin-1, but finally the most effective treatment was the plasma of patients who recovered. And you did exactly the same in Wuhan. So plasma therapy seems to be the more promising, exactly like in Ebola pandemics. So my conclusion is that we don't have an effective therapy against coronavirus. Neither tocilizumab, neither chloroquine, neither remdesivir, neither any type of antiviral therapy. Only a promising activity is deriving from the plasma of patients recovering. That can be really an effective therapy.
So, do you have these trials in Italy now?
Yes, we have the trial with tocilizumab. Yes, we have.
So
but now the number of cases is very low. You know, we are not in the peak of pandemics now. We have less than 1,000 cases per day, and no one is in intensive care. So absolutely no patient in intensive care unit. So we started this trial 1 month ago. And now the analysis is showing that in very advanced cases, there is no activity.
Yes, that's the same. We have no patients anymore here now. So it's very difficult to carry out the clinical trial. But maybe next year, maybe in this winter, will be open again, I think. Yeah.
Thank you, Professor Curiglian. I have another question regarding the artificial intelligence graft drug selection, because our collaborator Justin Stebbing has selected the baricitinib from the AR graft, and the baricitinib mainly focused on the intracellular targets of JAK, but also we can see the IL-6 inhibitor, IL-6 antibody tocilizumab, they acted in different parts of the cellular. Would you say your comments on the different drugs of targeting the IL-6 and the JAK inhibitor and also interferon?
But you know, all of them are finally interfering with inflammation at the different stage. So if you target IL-6, you target the late stage of an inflammation, because you know, tocilizumab is actually approved for septic shock. So when you have really a late stage shock, you use tocilizumab in order to stop the inflammation cascade, like in CAR T-cell therapy. If you interfere with other targets, as you mentioned, like TNF, or other early precursor inflammation, maybe you have much more opportunity to shut down the inflammation process and to give much more benefit to the patient in the early stage of the infection. So the more earlier you intervene, and both better results maybe you can obtain.
Thank you.
Can you tell some progress of the research on vaccine for COVID-19?
You know, also this type of approach has been tested in Italy, but actually we don't have any final results regarding this. We know the paper that have been published, and then FDA approved the drug. Also, the regulatory agencies approved the use in Italy. But I must confess, if you ask me, did you see any important improvement in your patients? My answer is definitively no. So I don't see really a breakthrough effect of this agent in my patients.
So I think you have answered all my questions. So my last question is, what's your comment for how can we face to COVID-19 in the future for our routine work in the hospital? How can we do that? Do we need to screen every patient when they enter the hospital? This time we found that many healthcare workers infected heavily. That's right. I think that's the same in Italy. So when your daily life in the future, how do you control for that?
What I suggest to do is to proceed with testing all patients who are admitted to the hospital. And so this is what we are doing actually in our cancer center, and to perform a CT scan, of course, to exclude the presence of active infection, and to provide with personal protective equipment all the health professionals. So the best way is to limit the access of infected people in the cancer centers. If you discover infected people, you isolate them, and then you can take care of all the other patients. So this is, I believe, the best strategy in order to guarantee the best of care for cancer patients.
So do you use the telecom care for these cancer patients?
Yes, for patients who need to do follow-up visit, we use telemedicine. Also, all patients that are receiving oral medication are finally receiving the drug at home, and we do a safety monitoring with telemedicine. So we try to do telemedicine for everything we can do, from follow-up to safety monitoring of oral medication. Of course, there are some patients that should be admitted to hospital, and those patients are those who have to receive surgery and who have to receive intravenous treatment.
Okay, yeah. I think that's a good way. Maybe a new fast development for this treatment. So do you think for cancer patients, do you think the threat for compared with COVID-19, is the primary disease more dangerous for them, or COVID-19 is more dangerous? If the patient he suffered with such as leukemia, they can't wait, and meanwhile they may suffer with COVID-19. So when you make the choice, so which do you think is more dangerous for them?
I believe you should prioritize in a leukemia patient cancer treatment. A leukemia patient cannot wait. So you test him for COVID-19. If it is negative on the swab, you start treatment and you try to protect him. Leukemia is more dangerous than COVID-19 in terms of mortality if you don't treat the patient.
So I found a lot of patients, they died, not for COVID-19, but for other disease. That is a secondary disaster, I think. That's more important. So maybe we should face to that.
Yes.
Yeah.
I believe now we need to concentrate much more on our cancer patients, at least in China and in Italy, where now the COVID-19 pandemic is under control. Now it's time to take care of our cancer patients, protecting them, but we need to take care of them.
Correct, I think. Recently in Wuhan, we just finished a test for nuclear tests for 1,000, that is 10 million people, our whole city, and no no one COVID-19 patient.
Yes.
No one. No exist. So it's very safe in Wuhan now. I think it's also safe in Italy. Yeah.
We have still some cases all over the country, but you know, it's just in Regione Lombardia, that is in the north of Italy, but cases are decreasing day by day, okay?
Do you think it's because summer is coming, the temperature is important? Do you think so?
I believe this is related to the lockdown, primarily. Maybe to summer, but primarily and scientifically to the lockdown.
Yeah, maybe. Yeah, I hope so. Yeah.
You know, I would like just to mention the CCC19 and the terawatt data presented during ASCO, and they clearly showed that older age, comorbidities, and chemotherapy are risk factors for cancer mortality. And another important thing is that as we did with our colleagues from Wuhan and other centers, first, we don't have to forget for the next pandemics shortage of medical resources. So some treatments can be delayed in the metastatic setting. Some others no, because you cannot delay a treatment for a leukemia or for a high-risk cancer. So we have to be prepared for eventually any other future pandemics. And we should reorganize our health systems, having a personal protective equipments for all health professionals, having a hospital just for COVID patients, and then hospitals for cancer patients, cardiovascular patients, and other type of patients. So this is the best lesson from this experience.
Yeah, thanks for your very good comment. I agree with you for that. Yeah, we should take more attention for older age patients, cancer patients, especially the blood cancer patients.
Yes.
Will face the next time. Yeah, that's very important. Prevention and take care, that's important.